or when your physician might recommend hospice. So a big part of hospice care, it is a palliative approach to care. So the goal of hospice is to focus on comfort and quality of life where you're no longer seeking any aggressive treatment. Our goal is to focus on providing that support to the patient and their family during their terminal illness until end of life. We look at the whole picture in hospice, so it's not just your medical care, but we also focus on the spiritual aspects of care, emotional aspects of care. We cover it all. It's a big, I always tell people, patients in the center, and then all of us are around you guys to provide that care and support to them. One of the most common myths of hospice is that we hasten the death process. We don't do anything to hasten the process. We don't do anything to prolong it. We let death happen naturally. And of course, the care is not curative, so you have to stop any type of aggressive treatment before admitting to hospice care. So as I mentioned before, there's a lot of people that are really taking care of the patient and the family. We have the medical director. You'll have a nurse that's assigned to your care, social worker, chaplain, hospice aide, and we also have hospice volunteers. We can also have therapy come in for hospice patients too, but therapy in hospice is more so for training or safety for the family or caregiver that might be taking care of the patient versus something that is, again, curative. We're not seeking goals specific to get you better. It's more so for support and safety and training. We address a lot of things in hospice. Again, like I said, it's not just medical, but we are, a big part of what we do is medical. You know, we want to focus on that symptom management, making sure all your symptoms are managed. So pain, nausea, anxiety, because sometimes anxiety happens during hospice care, depression. We focus on all of those things, but also the spiritual aspects. You know, if patients are religious or spiritual, we have a chaplain that'll provide that spiritual support for you. Also the emotional support. Emotional support is huge in hospice because sometimes we're doing more of that for the family than the patient. So making sure that we're counseling you throughout the journey, whether it's you or your family. And if it's beyond what we can provide to you, we will refer you to a counselor too. We also help with end-of-life decisions, so advance directives if you don't already have that in place, power of attorney, funeral planning. We can help with a lot of additional resources outside of just specific to hospice care. We also have a bereavement program for patients' family members. After a patient passes away, our chaplain provides support for up to 13 months. A lot of times people don't need bereavement initially. They'll tell us, you know, I'm okay, you know, because family's around, they're being supportive. And then when family goes away, they feel lost a lot of the time. So I've had people come back to me 6 months after their loved one passes away, and they're like, I'm really struggling. I'm having a hard time. So we just meet families wherever they are in that process too, or if we need to refer them out to somebody else for additional support, we'll also do that. So the principles of hospice care, hospice affirms life. And like I said before, we really focus on death being a natural part of the process because death is just as much important as the beginning of life. So we want to make sure that people understand that a lot of what we see in the dying process are very normal things. We again focus on pain and other symptoms, the medical care, the psychological care, the spiritual care. It's all integrated. We all focused on, and a lot of us do a lot of different things. We have a lot of different roles in hospice. It's not specific to one person. And again, being a support to the family as well as the patient is very important too. So when is hospice appropriate? So usually a referral to hospice is made when a patient is given a terminal illness, and in that terminal illness, they've reached the point where treatment is no longer effective. So say you have a cancer diagnosis, you receive your radiation, chemotherapy, whatever the doctor recommends, and you've reached a point where the treatment is no longer effective or beneficial. The doctor at that point might recommend hospice to you. There are a lot of different diseases that we look at. We look at end-stage heart failure, COPD, that's end-stage, dementia, that's end-stage, Parkinson's. There's a lot of different diagnoses that we use in hospice care. But at that point when you're electing for hospice, you're electing for palliative treatment only, no longer seeking aggressive treatment, and that's including going back and forth to the hospital too. And then, of course, with Medicare, it requires the physician to say that you have a terminal diagnosis, that if that disease follows its natural progression, you have 6 months or less. And that 6 months or less term, we use that very loosely in hospice because people can live a lot longer on hospice. People can live a lot shorter on hospice. And we have sometimes people graduate from hospice. So that term is very loosely used, but in that moment where you're progressing and you're at that 6 month or less mark, that's when the doctor has to be able to say, okay, this is what I think if it continues the route that it's going.
And I think it's important, just like Jasmine was saying, that it's an objective process
Yeah.
that the physician will assess things on. I think a lot of folks just assume, hey, if I feel like it's appropriate, can I go on hospice? And the truth is, it's a subjective, basically, assessment that the physician will render.
Yes.
So.
And payment for hospice care, most folks that we admit to hospice are 65 or older and have Medicare already. So Medicare covers hospice at 100%. Sometimes we admit patients to hospice that are younger and have commercial insurance, but we will always run their insurance benefit to make sure that they don't have a big out-of-pocket expense. And if for some reason we can't provide the service, there might be another agency that can for those other outside insurances. Another big question that we get in hospice is, where can hospice be provided? Do I have to leave my home? The answer is no. We can provide hospice in just about any environment. So that's home environment, independent living, some assisted living facilities, long-term care facilities, and in hospice houses. Our goal in hospice is not to take anybody out of their home. We're big advocates for people staying in their home as long as it's safe and you have the support in addition to us. We don't admit people to hospice and say, sorry, you got to go to healthcare, or sorry, you got to go to another nursing home. Our goal is to provide the care wherever you consider home to be for you. And again, we can provide hospice in most settings. And a lot of times we admit patients to hospice. I've admitted patients to hospice that have been very independent, still driving even. So if they are independent, they're driving, they're doing okay, we manage them like that. Now, if they start to change where they're saying, hey, I'm having more difficulty with bathing myself, with prepping my meals, with getting dressed, with doing my day-to-day tasks, we work with the patient or the family on hiring help. So you might have to have outside caregiver support, but we also help with that resource too. So this lovely will Andrew created here. But when I describe hospice to patients and families when we admit them, the patient and the family are the center of what we are doing. And I tell every patient, you are the boss. Our goal is to support you, to honor your wishes, and making sure that we are providing the best care to you. We're not going to bark orders down to you about what you should be doing in regards to your health care at that point in time. Our goal is to provide the education and to support your decisions. So you've got this big team of people. Like I said before, you've got the medical director, the hospice nurse, hospice aide, chaplain, social worker. Some people even keep their community physician if the physician agrees to follow their hospice care. That is also an option. Some people don't keep them on as far as going to see them, but they want the community physician to be updated on their course. So we can also do that too. And this is our hospice team. And again, the hospice team, it includes the patient, the family, the physician, sometimes the patient's primary care physician if they choose to continue to see them or want them to be involved, nurse, social worker, chaplain, aide, and volunteers. Now, bereavement, we touched very shortly on bereavement earlier, but bereavement is provided to patients' family members after a patient passes away, and it can go for up to 13 months. That amount of time is not specific to 13 months. If you only need it for a couple of months, so be it, that's it. But just knowing that you have support outside of hospice, even after the fact, is nice. A lot of times, especially our community patients, their families get very used to us coming in and being that support system for them. So sometimes they need that continued support just to converse. Sometimes it's talking about any and everything. It doesn't have to be grief specific, but just knowing that they have somebody that they can call if they are having a hard time with the grief or they just want to talk. And it can be, we can also do support groups. It can be booklets on why you feel the way that you feel in the grief journey and normalizing a lot of what's happening to you. We've also helped families do memorial services. Our chaplain has done many memorial services for patients, so we are more than happy to help with that if people don't have those planned. Now, if someone doesn't qualify for hospice care, a common thing is that palliative care and hospice are the exact same thing. Palliative care is not hospice care, while hospice does follow a lot of the palliative care processes and all that. It's a little bit different. So if someone mentions palliative care to you, like a physician says, hey, you might need palliative care, it's just basically saying that, okay, you're at a point in your illness where we're not able to do a whole lot for you, but you are still benefiting to potentially seek treatment or go to the hospital. Palliative care still focuses on the symptoms, but it's not saying you're electing to do nothing. So hospice, you're saying, okay, I'm at the point in my disease progression where treatment is no longer effective. Going to the hospital is literally like putting a Band-Aid on the situation rather than fixing it completely. So you're saying, okay, I'm not electing to go to the hospital. But palliative care, again, you have somebody assigned to you to focus on managing those symptoms. So pain management is huge in palliative care too. But you have a little bit more flexibility as far as treatment goes. You can still seek treatment while on palliative care, but while you're on hospice care, you can no longer seek treatment. So we have our own version of the palliative care. It's called the Hospice Bridge Program. Now, this program we designed to help people that are either appropriate for hospice but not ready to emotionally accept that they need hospice, or for people who have a life-limiting illness but they're not yet at end stage. So our goal in the Bridge Program is to provide a lot of end-of-life education and end-of-life planning. So we focus on advanced directives, power of attorney, helping with funeral planning. If somebody is still wanting to do CPR, focusing on talking about discussions around becoming a do not resuscitate. And it's really helps with that transition into hospice, because the people that also help provide care and bridge will also follow you in hospice care. So it helps build that rapport and establish a relationship prior to going on hospice. Usually myself and the chaplain provide that service as far as bridge goes, and usually it's a monthly visit. In addition to phone calls, checking in to see how things are going. We can have a nurse come out and assess the patient if we feel like the patient's really declining, and report that back to the doctor as well. Again, the goal of the Bridge Program is to really focus on those end-of-life planning and those goals and what you want, and also letting your family know what you want, because sometimes people's children have no idea what their parents want and what the care would look like for them at end of life. So making sure we have those conversations and including family is important too. Our Bridge Program is free of charge. We do not bill the patient's insurance for it. We don't bill the family for it. So it's something that, again, the goal is to eventually transition to hospice, which is why we do it. And we can provide the Bridge Program as well in any setting. So home, assisted living, long-term care, wherever you consider home, we can also provide that service. Now, once the patient is hospice appropriate or ready to say, I'm ready for hospice, we would reach out to that patient's physician to arrange an order and a referral to hospice. And that's it. Does anybody have any questions about hospice, the Bridge Program? Yes, ma'am.
Please clarify about where you can be. Let's assume I'm in the healthcare unit and the hospice is declared for me. Am I left in the room I'm already in and treated there, or am I moved someplace else?
No, you stay right where you're at. We do not move you.
Okay.
Yes, ma'am. Any other questions? Yes, ma'am. We don't have a hospice house with our hospice, but what we do, we will work, if like say your dad was at home, we would find a place for the patient to go to. So we would work with the facility and make sure they have appropriate placement. Yeah.
And excuse me, I was going to say, we do have brochures and that sort of thing up front as well. So anybody that would like some carryouts and information there, we have that for you as well.
Mm-hmm.
And that'll have our information on it, so you can always give us a call with any questions that you might have later.
Any other questions?
All right.
Okay.
Well, in that case, we're going to bring up the Honorable Reverend William Deal here. He's going to speak to you a little bit more about everything he's going to talk about.
Yeah. Lots
I'll
of
be
stuff.
honest with you, yeah. I didn't want to steal any of your thunder, my
Hey,
friend.
no, you can
Yeah.
steal away. Steal away. Thank you all.
Thank you.
Let me get behind the microphone. If I've said it once, I'll say it 1,000 times. And I don't just say this because they are a part of Westminster Canterbury, but Westminster at Home Hospice is top-notch. I've worked in previous positions and also seen my dad in action. Don't tell him this, but they're just as good as my dad is, and I think a lot of him. No, they are rock stars. From the nurses to the social worker, the chaplain, the aides, even the director of marketing or whatever Andrew's title is. They are awesome. And they also are available for any time you have a question. Like, don't wait until you are needing to have the hospice conversation to ask some of those questions. They are available and are happy to answer some of those questions. Before I begin, I printed 25 of these initially, and then I came in and I looked and I was like, maybe I need a few more. This is, I'm just giving to you as a resource. This is from the National Institute on Aging, and it's just getting your affairs in order. So, for those of you who have been participating in this transitions program over the past 5-6 weeks, we are moving toward the final transition, death and dying. And I know that it's not always the most comfortable thing to talk about, but I think it's so necessary to begin these conversations early and not right in the midst of it. So I'm going to hand these out, or what I may do is just hand 2 stacks and let y'all distribute them. And if you need more, I can always print more, just not right now. But while you're passing it out, on the first day of creation, God created the dog and said, "Sit all day by the door of your house and bark at anyone who comes in or walks past. For this I will give you a lifespan of 20 years. The dog said, "Whew, that's a long time to be barking. How about only 10 years and I give you back the other 10? So God agreed. On the second day, God created the monkey and said, "Entertain people, do tricks, make them laugh. For this, I'll give you a lifespan of 20 years. The monkey said, "Whoa, monkey tricks for 20 years? That's a pretty long time to perform. How about I give you back 10 like the dog did?" And so God agreed. On the third day, God created the cow and said, "You must go into the field with the farmer all day long and suffer under the sun, have calves and give milk to support the farmer's family. For this, I'll give you a lifespan of 60 years. The cow said, "Whew, that's kind of a tough life you want me to live for 60 years. How about 20 and I'll give you back the other 40. And God agreed. On the fourth day, God created humans and said, "Eat, sleep, play, marry, and enjoy your life. For this, I'll give you 20 years." But man said, "Only 20 years? Could you possibly give me the 20, give me my 20, the 40 from the cow that he gave back, the 10 the monkey gave back, and then the 10 the dog gave back. That makes 80. Is that okay?" "Okay," said God. "You asked for it." So that is why for our first 20 years we eat, sleep, play, and enjoy ourselves. For the next 40 years we slave in the sun to support our families. For the next 10 years, we do monkey tricks to entertain the grandchildren. And for the last 10 years, we sit on the front porch and bark at everybody. But as we age, as we move closer to the end of life, we don't know exactly when that will be for each of us. Sometimes it's good to have some humor in there, but what I want us to remember first and foremost is that there are two things. Death is both universal and unique. Just like grief is universal and unique. Death is a universal human experience that is beyond our comprehension. I better advance a slide. There we go. Death is a universal human experience that's beyond our comprehension. We know that all things that live will eventually die, yet dying can only be imagined. The subject of death and dying often causes fear and anxiety, and so we tend to try to soften it a bit by saying things like, kicked the bucket, or the big adios, or another one bites the dust, or the eternal rest. I've got more, don't worry. Or to cash in your chips, or to cross the Jordan, to give up the ghost, to push up daisies, shaking hands with Elvis and Jesus. Had never heard that before until I was preparing for this. Taking the train to glory land, went on to be with the Lord, moving up to glory, and one of my favorites from our very own CFO, who I will not name, but I'll tell you his name rhymes with Schmal Spelton. The celestial discharge. There are certainly more phrases like these, and I do mention these in hopes of getting a few smiles and laughs, but I say these for another purpose, and it's more important. We often use these euphemisms as indirect, evasive, protective ways of saying more direct things like death, died, dying, etc. So fair warning, we're going to talk directly about death and dying and end of life. Talking about and preparing for death and dying are not things to be avoided or to be approached with fear. Rather, learning to talk about and prepare for death is a gift. It's a gift to you. It's a gift to your loved ones. And so, what is death? Death is certain. Death is universal. It is personal and unique. It's incomprehensible. And it's more than just a physical process. More on that later. It's incomprehensible because we can understand death at an intellectual level, but we cannot comprehend death at a personal, experiential level until it happens. Now, there are certainly people who have had near-death experiences, and I'm not denying that, but those are not super common. I think a lot of times it's not so much that we are afraid of death per se. Many people get up in years and get near the end of life and feel content and are okay with whatever may be next. But it's the dying because none of us have ever experienced it. Death is more than physical. It's spiritual. And when I say spiritual, I don't necessarily mean religious. Spiritual has to do with our connectedness beyond ourselves. It could be to a higher power. It could be to others. It could be to nature and creation and all of these things. But more universally, when I say spiritual, I'll quote the Oxford Dictionary. The quality defines spirituality as the quality of being concerned with the human spirit or soul as opposed to material or physical things. Social scientist Brené Brown says, spirituality is recognizing and celebrating that we are all inextricably connected to each other by a power greater than all of us, and that our connection to that power and to one another is grounded in love and compassion. So practicing spirituality brings a sense of perspective and meaning and purpose to our lives. And so this death is spiritual because as we approach it, we begin, or if we haven't already, begin to have these conversations with ourselves and maybe out loud with others of, did my life have purpose? Did it have meaning? Did I lead a good life? Just this past week at Thanksgiving, I sat with my almost 92-year-old grandmother in her home in the Outer Banks. My grandfather died 2 years ago, and they were fantastic partners in life. They weren't always cheery with each other. They butted heads some, but that was not evidence of their lack of love, but really their love. And my grandmother looked at me and she said, "Sometimes I wonder, William, why am I still here?" That's a tough conversation to have, and I'm very capable of doing it. That's what I'm here for. It's much more difficult when it's my own grandmother. So I sat in silence as I've been trained to do, and not to try to overstep. And I just waited and I looked and I said, "You wonder why you're still here?" She said, "Yep, Papa's not here." And she's other than having a fall a few months ago and breaking her pelvis, she's fairly healthy. She said, I've lived a good life, and I'm okay with it. I'm okay with whenever death comes." And I said, "Well," and I did begin to speak after a little while, and I said, "I think that's a very healthy place to be." A lot of people, as they approach the end of life, they begin to have all these anxieties and fears and worries of, did I do enough or not do enough? Was I this, that, or the other? And it's filled with anxiety and despair almost. And to be able to begin to process that now and not as death is very quickly approaching is a gift to yourself, to be able to reflect upon your life. And then it can be for many people religious, connected to a higher power, our beliefs, our values, our traditions. For many people, there is part of the peace of approaching death and dying is the promise, the hope for what lies ahead, whether that is heaven or some form of eternal rest or whatever that may be. Because I recognize that there are many religious and spiritual beliefs here. Many overlap, but they are different. But those things give us a sense of peace. Death is also existential. Our connectedness again to the world, to creation, to other things as well. It's also psychological and emotional. Our connectedness to ourselves. And as we continue to age, it's possible to have feelings of a loss of identity. There's the psychosocial processes. I'm a big fan of Erik Erikson's stages of psychosocial development. When I learned it in college, I always viewed it on an upward trajectory. That first stage, I don't know if any of you have studied Erik Erikson. I'm not going to give you the full rundown. We don't have time for that. But it's the trust versus mistrust that we learn. That's that psychosocial development at infancy, where our first psychosocial development is learning to trust based on the care of our mother, our father, those who we can be held and not have to fear that we're going to be dropped and things like that. But I don't think, and then the next one is autonomy versus shame and doubt. This is during the potty training stage. Can I take care of myself and do my business, or am I going to experience shame and doubt? But I don't think it's so much an upward trajectory that ends up here. I think it's somewhat cyclical, because I think we eventually kind of find ourselves where we're reverting back to some of these things and having questions, and it's good to begin to think. Let me pause there. I just went very tangential, and we don't have time to go too much farther, but I'd love to have a conversation over lunch sometime with anybody else that wants to. But the seventh stage is this generativity versus stagnation. It moves into this idea of the virtue is care. What have I done, or what can I still do to contribute to this world? And then that eighth stage is integrity versus despair, and the virtue is wisdom. Did I live a meaningful life? And so you can see that we're trying to have a conversation about the final transition in 30 minutes or just over 30 minutes, and this is not meant for just that amount of time. Also, death is social, our connectedness to others, our human relationships, wanting to have meaningful conversations with loved ones. I think there is, focusing on the social, there's a universal epidemic of wanting to be fixers. I think we're pain avoiders, and so that's part of the reason why talking about death and dying is so hard, is because there's not a solution to it. Death is not a problem to be solved. It is universal, but it's unique. It's an opportunity for us when we are going through death, or a loved one of ours is going through death, to be fully present in that experience and to be present with one another's. Presence matters. We don't have to fix things, but to just be with each other. Atul Gawande is a surgeon. He wrote the book Being Mortal. I know several folks have read it. It's an excellent book, but this is a quick summary. But he tells of his experience of shifting his mindset in the medical process from always trying to provide a solution to heal, to fix a problem, and while missing out on what it means to live a good life all the way to the very end. Yeah, I spoke a couple of weeks ago. I presented at the University of Lynchburg for their Healthy Aspects of Aging class. And it's a part of their health promotions class. And I had this realization as I was standing there before them. All of the people in that class are going on after college to pursue some type of helping profession, specifically in healthcare, in some way. We spend so much time trying to learn more about how to live a healthy life and how to do more and be more and all these things, but we don't really spend that much time talking about how to live a healthy life even at the end of life. I changed some slides, but I had in here, blues musician Albert King's "Everybody Wants to Go to Heaven, but Nobody Wants to Die." So why is talking about death? Oh, there it is. Death and dying so difficult. Some of the reasons that our relatives, our friends, our neighbors, our loved ones may not want to talk about it is a fear of saying the wrong thing and making matters worse. We have a fear of loss. We have a fear of what others might say, the notion that professionals know best, so nothing is addressed. We begin to fear our own mortality. We have guilt or shame about what's happened in the past, and sometimes it's denial. But I think when we deny others the opportunity to speak of death and dying, we're denying them an opportunity to share some of their soul, some of their spirit with us. And so why do people who are dying don't want to talk about it? We don't want to think about the end. We don't want to address our own mortality. Maybe we have a fear of being a burden to our family and friends. Maybe we're just private people. Maybe we have some inner conflict or feelings of unfinished business. Maybe we have fractured or strife-ridden families. Maybe we're afraid that some secrets of the past will become unearthed. Maybe we too are experiencing denial, or we don't want to upset others. Maybe I've never been a talker, not me, and I don't want to start now. Why should we talk about death? Talking about death doesn't bring death closer. It's about planning for life. Without communication and understanding, death and terminal illness can be a lonely and stressful experience, both for the person who is dying and for their friends and family. We've separated living from dying as if they are ultimate dichotomies or ultimately polemic, on the opposite poles. And I've come to really understand and really appreciate the connectedness of this life and then the life that is to come. And we often view death as the disintegration of life. But I wonder if it's possible for us to shift our understanding and integrate life and death into the whole of what it means to be fully human. And so, as I said, the ultimate goal is not a good death, but a good life, all the way to the very end. And then this quote here, whoever rightly understands and celebrates death at the same time magnifies life. So let's not be afraid to talk about death and dying, especially with our loved ones. Our family, they need to know that we are at peace. Death is a natural part of life. It's as natural as birth. Death comes whether we expect it or are prepared for it. It can come at any time. And the dying often want to die on their own terms. Nothing can prevent death. It will come upon all of us. With each passing breath, we move closer to our death. Therefore, let's always try to live fully while we still can. Sometimes the one who is dying needs permission to let go. The dying often need assurance from family that they will be okay after their loved one is gone. Sometimes death can be seen as a gift in which you can celebrate the life of your loved one. The person who is dying will often give a final gift to their loved one for the assurance that they will be okay. The final gift will come in a variety of ways. It could be verbal. I want to go home. I'm ready to go. Or sometimes it's through a touch or a blink of an eye. What does death look like? We're not going to spend too much time here, though I think it's important because many people have not been around someone who is dying. And now let me say, as universal, it is all as death is, it's also unique. And so some of these things are not. It's not going to always happen like this. It's not a prescription, but things to just be aware of. But a great resource, and I should have brought my copy, and I forgot. It's called The Needs of the Dying, A Guide for Bringing Hope, Comfort, and Love to Life's Final Chapter by David Kessler. And it's an exceptional book, whether for your own, if it's something you would like to check out or pass along to someone else. Many dying people appear to be struggling toward the end as if the body and the soul have been intertwined for so many years. Don't want to let go of each other. It's often terribly painful for us to watch this struggle. Death is as primitive as birth, often loud and messy, but it's always deeply authentic. We can find peace and dignity in the authenticity. One thing, here we go, There's the book. One thing that I think it's important for us to remember is that as the body dies, it's like a factory. When you turn off power to a factory, everything doesn't just stop. There's still gears that have to turn and belts that have to move and electrical components that are still having a little bit of firing. And so sometimes death is a longer process than we might expect. And so the struggle of death and the peace of death. Death is universally defined as an irreversible cessation of brain, respiratory system, and circulatory system functioning. So what happens when we die? Some of the common signs, and as I mentioned, there's no set order for these, but sleeping often increases, eating and drinking decreases, and that can be really challenging. I've been with several family members, with some of our residents who are transitioning, and they worry because, well, they haven't eaten or they haven't had any water in so much time. We have to remember that as their body's shutting down, they don't require as much to sustain them, and that's normal. Of course, incontinence, breathing slows and becomes irregular. hypoxia or low oxygen levels, cyanosis, which is the bluing of skin. Sometimes there are convulsions, and I remind folks when those happen, because they can be very unnerving and alarming, that we are electrical organisms. We don't plug ourselves up to a wall, but we have electrical movements going through us, and sometimes those things are just our body processing differently. Sometimes, of course, there are differing odors. There's fever and sweating and restlessness. The heart rhythm slows and weakens, and the circulation slows. I came in toward the second half of the hospice conversation, and they are far more the experts on the hospice process. But one thing that I do want to make mention, if for someone who is admitted to hospice, it is common for the doctors and the nurses to prescribe and give medication like morphine and Ativan. Morphine to help with pain, and Ativan to help with anxiety, to help people be calm and at peace and as pain-free as possible. But a lot of times people hear morphine and they initially think of it as this very aggressive, death-hastening drug, and that's just simply not true. It helps to keep people as pain-free as possible. Again, they're exceptional the Westminster Home are exceptional resources for some more of those questions. Changes in the eyes. Hearing, I believe, and many others do, that hearing is the last sense to go. So you may be with someone who is dying, and you may think, well, should I even say anything to them? Do I talk to them? They can't hear me. They're not responding. I firmly believe that hearing is the last sense to go. And so if you have a desire or an opportunity to speak to someone who is dying, do so. Your presence, even if you think it doesn't matter, I think it really does. Sometimes there are strange noises or even shouting. There's also something called the death rattle. I wish there was a better name for it. But if you've ever been with someone who is dying, often as they breathe, you'll hear almost a gurgling sound, and that can be very unnerving as well. But I always remind folks when I'm with them and I sense that anxiety, that it's just the sound of air passing through water. They are not, or through liquid, I should say. They're not choking. They're not struggling to breathe. It's just the sound of it kind of moving through, and it's much more natural. Now, of course, there are times when we need to be more concerned about breathing, of course. But sometimes, of course, there are secretions and foam from the mouth. Oh, there's the death rattle. Already talked about that. So what are some of the needs of the dying, which is getting to the rest of this, which is planning for end-of-life care? The need to be treated as a living human being. That is one thing that I try my best to do. A lot of times families will talk around a loved one who is dying, and not just families, but people in general, as opposed to talking to the person, keeping them a part of the conversation, even if they're not able to respond as much as they might have been to the conversation, that they are still a living human being with needs, with a need to be heard and listened to and understood. And so that is primary. A need to maintain a sense of hopefulness, even if it changes. A need to be cared for by those who can maintain a sense of hopefulness as well. A need to express one's feelings and emotions about death in one's own way. Another thing, when speaking about this specifically, but also grief, I am very slow to offer tissues to someone who is crying because of grief. Our first response when we see someone crying, especially because they're experiencing some type of grief, is to throw a tissue at them to sop up their tears. And what I've learned is that can sometimes cause them to stifle what they're experiencing. I have tissues in my office available if anybody needs them. And eventually, if they start snotting on themselves, I'll give them a tissue. But I think we're so quick to try to rid ourselves of any type of pain that when someone else is experiencing it, we try to give. And I know that's not the intention, but I make it a practice to to not race to give someone a tissue because I want them to know that they can share their emotions, their feelings, what they are going through. Another need is the need to participate in decisions concerning one's care. Now, ideally, you can do that. Some people are able to do that all the way to the very end. But for a variety of reasons, various diseases or illnesses or tragedy, people are not always able to maintain that autonomy to the end. And that's where advanced medical directives will come in. The need for continuing medical care, even though the goals may change from cure to comfort, to have our questions answered honestly, the need to be free of physical pain. I've read in several places that with modern technology, with medicine, no human being should have to die in pain. Now, I recognize that sometimes that happens, but we have tools, we have methods, we have things that can help people die peacefully and as pain-free as possible. The need to speak about spirituality, the need for our children and family to participate in death, and the need to understand the dying process, the need to die in peace and dignity, the need not to die alone. Just this past week, we had one of our residents who was actively transitioning, and her family lived several hours away, and they were on their way. And the hospice team reached out to me and our hospice chaplain, Bill, and said, hey, would y'all be willing to come over here? Well, I went over there, and there was a nurse with this resident, but I knew that I had family obligations that I had to attend to, and so I went back to my office. I sent an email out to our pastoral care volunteer team, and within a matter of minutes, we had folks going over there to sit and just to be present, not to do or say anything, but just to be with the person so that person did not have to die alone. And I just want to say thank you to those who went and those who offered and those who have been available. That is such a gift to be with someone so they don't have to be alone while they're waiting on family and while our staff are still busy caring for others as well. And the need to know the sanctity of the body will be respected after death. So the ultimate goal is not a good death, but a good life, all the way to the very end. And so I believe that preparing for this is a gift. I know it sounds weird, but it is. It's a gift of empowerment, allowing you to communicate your desires and your wishes, and it's a gift to your loved ones to have a peace of mind. So there are two kinds of advanced directives for health care. First and foremost, let me say, a lot of times when we talk about wills or end of life or trusts or these kinds of things, we often overlap the advanced directives for health care and the financial piece. And so let me say, the person who, or ideally a person, or maybe a primary and then a secondary person that you pick as your health care proxy or agent, in legal terms, your power of attorney for health care, does not have to be the person who's going to handle your stuff after you die or handle your finances while you're still alive. Those can be the same, but what I'm talking about, and I'm not necessarily talking, let me say, I'm not giving any legal advice. I'm glad to talk about these things even in private conversations, but I will never tell you what you should or shouldn't do. When I was in between my church position and here, I worked at a hospital, and it was weird to me that one of my primary responsibilities was to help people complete their advanced medical directive. I thought it was weird because I was like, what am I here for? But then I learned that I didn't wear a white coat or a stethoscope. I wasn't going in there to take something, vitals or information or whatever, but I was there just to be with them. And so I have experience with this if you would like to talk through it at a different time. So 2 different types of advanced medical directives for healthcare, even though they are often the same thing or in the same document. First is to appoint an agent or a proxy, or in legal terms, power of attorney for healthcare. One thing that's important is that an advanced medical directive is not, once you assign the agent, the proxy with power to make those decisions for you, they can't just arbitrarily start making decisions for you. An advanced medical directive is like a light switch. It is only turned on if you are unable to make those decisions for yourself. That can be kind of scary to say, here are my wishes, here's how I want this or I don't want this at end-of-life care, and to think, oh goodness, well, they're just going to, take me on out of here quicker than I want to go. It's not that. It is like a light switch. And then the second piece of it is kind of like a living will, though there are some differences, to state what kinds of health care you want or don't want if you are determined to be unable to express your own wishes. And as I said, it doesn't provide authority over financial or estate decisions. So, preparing for end of life. If you haven't already, start the discussion now with yourself, with your spouse, with children or loved ones, or a trusted friend who can help you through this process, but also so you can communicate your decisions. Create those. This is all in the handout I gave you. Create those documents for healthcare, financial management, end-of-life wishes. Go ahead and do that now. Review the plans. They can change. Did you know that in the states are different. Each state is different. In the state of Virginia, you could be sitting at a restaurant for dinner and decide that you want to make some decisions for yourself about your health care, and you could write it on a dinner napkin, sign it, and date it, and that would satisfy. I think that's a little weird, but there's not just one set form in the state of Virginia. And so I have a few resources, and we don't have time to talk through all of them, but I just saw, Frank mentioned to me and wanted to make sure that I was aware of this, and I am. This is Have You Had the Talk? It's put out by Centra Healthcare. It is a wonderful resource because it guides you through the conversations, because looking at a legal document for some of us isn't always the easiest thing to understand, but this guides you and your loved ones through these conversations. And it has some great questions, not just about health care and how you want to be cared for, but also what task would you like to accomplish before you die? What does quality of life mean to you? What does a good death look like to you? What role would you like your loved ones to play in your dying? What kind of help and support would you like for you and your loved ones? But then it goes through and it has a bunch of questions that will help you complete this. And then it's got the more form stuff in there. Another great resource, which is put out by an organization called Aging with Dignity, is 5 Wishes. And so the 5 wishes are, 1, the person I want to make care decisions for me when I can't. 2, the kind of medical treatment I want or don't want. 3, how comfortable I want to be. 4, how I want people to treat me. And 5, what I want my loved ones to know. And so these are great resources. I have several copies with me here today. The Resident Life Office keeps copies there. You can ask any of them, any of me, and we will get you a copy or copies of these if you'd like. There are other great resources out there too that you may find. There goes my tangent thing. Putting important information in one place. I know a couple of years ago, and it may still be a resource, I know the medical services team offered folks the little red envelopes that you can put on your refrigerator. If you don't have those, contact the Resident Life Office. That's where you can keep all of your important forms so that nobody has to go searching for them if something were to happen. Make copies of your documentation. Share it with your primary care physician. Share it with your loved ones. I think we can keep a copy as well, and then give permission. That's all on that as well. You can also begin to plan for funeral arrangements, burial arrangements, or cremation, whatever that may be. So some of these questions, as we've talked about, where do you want to die? Do you want to die in home? Do you want to how important is that for you to be at home as long as possible? When you're approaching the end of your life, is there anything you want to do? How do you want to be cared for? After you die, what do you want to happen? Oh, and the 6 questions, which are from I believe they're from the Have You Had the Talk. If not, it's another resource. But you can see those there, the tasks you want to accomplish, quality life, a good death, all of those. There's the 5 wishes we talked about. So I want to pull this up really quickly, and then I know we kind of flew through that because let me see if this will work. I discovered this resource a couple of years ago, and I will figure out the best place, like on the resident website, to put this. I'll chat with Bill Booz and find a good place for this. But what I like about this is, if you're more of a you like to have the form, this is an online PDF that you can then complete all your information right there, and then go through. And it also provides some great information. I realize this is really small print. You probably can't read it. I'm really struggling even with the computer. But this was the important part, and I was looking for this quote, and I found it. Your advance directive is turned on, like a light switch, only when you are found to be unable to make informed decisions about your care. That finding must be made by your attending physician and a second physician or clinical psychologist, or if you're in a coma or otherwise unconscious, just your physician, after they personally examine you. Your advance directive is turned off when a physician examines you and finds that you are able to make informed decisions again. So it's like a light switch. It can be turned on. I know there have been several people who have experienced some type of trauma or accident or medical issue, and they become unable to make the decisions for themselves, but then they recover and regain their ability, and it turns back off. The goal of this is to allow you to make these decisions for yourself and to maintain autonomy, volition for as long as possible. Really quickly, I should have done this a minute ago. Some of the end-of-life decisions involve the type, what you want or don't want. Do you want to be put on a ventilator or on a feeding tube? Do you not want that? Do you want to be resuscitated? Which, let me also say, the DNR, the do not resuscitate, there are pieces of that in here, but that is a different process. It's kind of, they're overlapped, but they're not necessarily the same. So that is a different process that I'm not capable of completely talking about. Just the different decisions that you can make for yourself now, can communicate those so that your loved ones can maintain your wishes when the time comes, if the time comes that you are no longer able to make those decisions for yourself. I think that was all I had. Oh, I just do want to mention this. I had this in here. If you're not aware, the Westminster Canterbury Health Services Committee, my medical information is what I was referring to that you can put on your refrigerator. There are some medical support groups. The 2 or 3 Westminster Canterbury friends who share a deep mutual respect and confidence because they are to be trusted in helping to fulfill each other's medical preferences in a time of medical emergency. We have many here in this room and in our community who have a spouse or a partner of some sort that is journeying alongside. We have many widows and widowers who may not have family close, and you might want somebody who is close by who can help you in times of need. And so the 2 levels of these supports are a care partner and a personal advocate. More information, the Resident Life Office can get you in touch with the Westminster Canterbury Health Services Committee if you have more questions there. So some things to ponder. What does it mean for you personally to live a good life all the way to the very end? And what does a good death look like for you? So, let's talk about death and dying. Seriously. This is an invitation to a conversation about death and dying, and this is why they pay me the big bucks. No, but if you would like to have this conversation, I welcome you to schedule a time, stop by my office anytime. Would love to talk with you about that. Any questions? I know we kind of flew through all of that. But. just remembered one thing I wanted to say. I thought about it when Andrew and Jasmine were talking about the big wheel, which I love that, of who's involved with the hospice team, but that the person is at the center. One of those is the chaplain services or spiritual services, and I know sometimes people are admitted to hospice and they're asked, do you want chaplain services? And sometimes people deny chaplain services for two main reasons. One, well, I already have a church, I already have a pastor or a priest or a rabbi or whatever. Or two, I'm not religious. Let me go ahead and say that both I and Bill, our chaplain, our hospice chaplain, are not here to take the place of your pastor, priest, or rabbi, but to be a partner on the journey, to be a spiritual support for you and your family, not to take the place of that person. And also, there are people who are not religious or and think that chaplain services or spiritual services, they're excluded from that. That's not true, because we are first and foremost interfaith chaplains here to be a part of the journey. No matter what we think, believe, no matter our religious history, faith, tradition, whatever, we all have emotional and spiritual needs. And so we are here for you. So I just wanted to share that. We are trying to be partners, friends on the journey, not try to convince you to think or believe something or to take the place of your church, your synagogue, your rabbi, your pastor, priest, guru, whoever it may be. So, any questions? I know we're at the end of our time. All right. Well, thank y'all. Anything else, Lee? Oh, I do have some copies of these if you'd like them. You're more than welcome to take one. Oh, thank you.